Nothing is as important as the slope of hospital and physician-delivered care. And that's today. On the right, on your right, that's going from today out to 2017. There is no way you'll get to $4.3 trillion of healthcare expenditures. That cannot happen. Something will happen to hammer that curve down. It has to. And not just because of commercial insurance, but because of the government. This is the slope for Medicare and Medicaid. This is the famous bend the curve slide that has been around for a while from the Congressional Budget Office. No way. And you know now that the Medicare program is essentially broke. You know that every state government, 40 out of 50 of the states are essentially broke. And so something's going to have to happen to hammer that down. And if that weren't enough, the only other place that you can go to get more costs out of the system is to continue to transfer it to patients. This curve is a frightening curve. On the green line going up is the increasing increase of out-of-pocket costs that the average American is paying. The bottom curve is wages. Does anybody in this room think that the wage curve is going to go up dramatically to close that gap? In fact, it's only going to get bigger. And so more and more costs are going to be borne by the individual. The point being that as the genetic revolution flowers, it flowers into this very serious cost conundrum. This is a paper that you now have that we released this morning from the UnitedHealth Group Center for Healthcare and Modernization, and if you don't have a copy now, it's in the back room. And my colleague Janine Voida will be talking more about what's in that. I will only make 2 points as what's in it. Number one, spending on genetic and molecular tests in 2010, we estimate to be somewhere around $5 billion, and that it is estimated that by 2021 they could be between 15 and 25 billion. So my only point here is, ain't nobody printing money. Ain't nobody printing money. America's small businesses cannot continue to pay more for health care. America's big businesses in a global economy cannot pay for more health care. Individual Americans cannot out of their pocket continue to pay more for health care. So the question will ultimately be, how does all of this fit in? Now, as we see this pace of discovery, complexity has always been a challenge for today's delivery system. It is always interesting to me to go back and relook at the Crossing the Quality Chasm report. If you haven't read it lately, you ought to just grab the executive summary online and take another look at it. 2001, it said we were in deep doo-doo in terms of the quality of care delivered in America. You know that about half the time, healthcare is delivered inconsistent with the best clinical evidence, about half the time. This is not an indictment of physicians. I like physicians. I'm the former senior vice president for professional standards of the AMA. I like doctors. I'm proud to be a doctor. Doctors went to medical school to do right. Not one person in my class decided to be last in their class. Well, except for this one dude. But other than him, everybody struggled hard to do well. And so the challenges of trying to deal with this complexity become very, very important, and we're going to need to do help. I mean, just trying to handle the array of stuff that's out there today is absolutely extraordinary. And so it becomes, of course, increasingly difficult as the days go by. And now we think 1,000 or 3,000, 1,300 genetic tests currently available, new ones emerging at the rate of several per month. And so the real interesting notion is now genetics has become medicine. So it used to, when Sharon talks about it, I was fortunate to serve both on the Secretary's Advisory Committee on Genetic Testing and then what came after it as the Secretary's Advisory Committee for Genetics, Health, and Society. And Sharon, I see my friend Steve back there and a bunch of folks around. Mark is here. A whole lot of people were involved in that activity. And it was funny, we used to talk about genetic exceptionalism all the time. And now no need to talk about genetic exceptionalism. Now genetics is just medicine. And so it's right there, and so all the complexities are there. Look at this. This is a very interesting slide for me because it talks about the facts per decision that a clinician must make. And from 1990 to 2020, the increasing complexity as we get decisions by clinical phenotype, structural genotypes, functional genotypes, ultimately the proteomics. The interesting line there is the red line, which is human cognitive capability. unless y'all have got some new mineral fish oil deal or something, that ain't going anywhere. So we're pretty static there. So if we thought it was hard already to incorporate new knowledge, it's going to really get difficult going forward. So our goals have to be shared. We have to have a shared vision. We've got to think about old problems in new ways and be exciting. I think this is always a good organizing vision. I mean, it's a place at least where you can have the grammar of coexistence. This is Don Berwick's slide when he was at IHI. He carried it with him at CMS. And it's the triple aim. And I think most people can salvage around in generic terms this notion that we ought to have solutions that improve the health of the public, that we ought to enhance patient experience with care, both quality, access, and reliability, and that we should reduce the per capita cost of care as goals. A reasonable way to at least have a conversation. Well, to do that, we need new breakthroughs in healthcare. True breakthroughs in healthcare are very, very rare. Usually what we see are incremental improvements which add to, I got this new imaging machine. It's just terrific. And we'll introduce that into the system. And guess what? We'll do the old test, then the new test. Now we don't know how to resolute the difference between the two, so let's do another test to figure out, and next thing you know, all we've done is go down the rabbit hole of ever-increasing complexity and costs. Halfway technologies compensate for the incapacitating effects of certain diseases whose course one is unable to do much about. It's characteristic that it adds money and requires expansion of things like hospital facilities. And so we've got to break through. This is why I think people are so excited about genetics, why so many people outside of the genetics family are now so excited and engaged and focused on you, because we understand now that we can get past these halfway technologies into something else. Well, that takes us to innovation, because innovation is breaking out everywhere. And it's exciting to see innovation all over healthcare. The thing that we have to focus in on is, can we find innovations that take costs out and improve quality? And that's what really everyone is hoping for. We're not interested in innovation for innovation's sake. This is an interesting book called The Innovator's Dilemma by Clayton Christensen, and he talks, and this is where, by the way, all that language comes from with safer, faster, quicker, easier, cheaper, all that sort of mantra that people talk about today. It comes out of this book, but he talks about the challenges of innovation and also the purposes of it. So first, I just cheated in terms of his comments to say that I don't give a hoot about innovation for innovation's sake. I got this new machine. It's got 3 more bells and 4 more whistles. You know, so what? Who cares? Is what does it do? Well, it must disruptively replace more expensive and less effective interventions, create new value propositions, improve performance based on new performance criteria. My phone that I have here in my hand is not competing against the old phone as a phone. This is an entirely different thing, right? The fact that it makes phone calls is fascinating, you know, to me. But the least of which I'm interested in necessarily is the phone, especially with my carrier. Optimize health outcomes. Make preventive and clinical care simpler and less complex to deliver, and this is the key, especially given the cost escalation. Move hospital care to the outpatient setting and the outpatient to the home and the community. And can you ultimately disintermediate the disease itself by getting to the root cause? Well, if we're going to see innovation and new exciting things, we have to know, does it work? No one is interested, again, in just innovation for innovation's sake. So, does the new thing work? Does it work better than the old thing, all in, all costs in? Diagnostics, therapeutic, count, you take it from end to end. Is the new thing, how does it work in comparison to the old things, everything in the mix? Then you ask the question, and this is where you're going to have to be very involved, because this is the horrible question you have to ask. If the new thing costs more money than the old thing, is the incremental value worth it? America has a hard time with that conversation, because if you're not careful, what I just said is kill grandma. People go right from where I just went to, oh, he's talking about killing grandma, because it costs too much money. So you got to be very careful even to raise this kind of conversation in the American discourse. And so it will take the genetics community and others, especially people like Sharon, quite frankly, not to put too much pressure on you, Sharon, But it will take people like her who can represent America's patients, who have the interest of affordable access to care that works, and who are desperate for innovation, to be able to have the conversation about value. And the conversation about value is an important one. We spend doodly squat on value, 0.1% on comparative effectiveness research, and even when we get federal money for it, you can't ask the question about cost. So it becomes very, very challenging. We have to find ways also of making sure that the regulatory pathway, and Congressman Greenwood just talked about it in terms of his focus from BIO's point of view. I am terrified of this problem because at one level, it used to be that the hurdle for success of proving that the new innovation worked was the FDA. But now it's comparative effectiveness research. So the hurdle is higher. What does that mean to the costs for innovators to develop new products? What does that do to investment in venture capital? And do you, by having a higher standard of value, have a chilling effect downstream on venture capital? So you've got to worry about how do you have that mix and that balance, and how do you do it without killing off innovation? And then there has to be, as most of you in this room, or many of you are involved in, a new regulatory science that makes the process quicker and faster. So companies like UnitedHealth Group, where I'm the senior physician, how do we signal to the innovators early at the beginning of development what the final exam questions will be? Here are the final exam questions that are beyond FDA. How do we sort of say, okay, let's start doing your clinical trials, your discovery work that is predicting where we've got to go that's beyond FDA so that it's efficient, as opposed to go from here, FDA, okay, now let's start over again, FDA, CER. So the notion is, how do you make that happen? And then how do you have a new regulatory science? So I'm excited to see what's going to happen between coalitions such as the NIH and FDA as they start to look at the science of regulation. And there are many people in this room who are very smart about those things, and we are really depending on you to get it right, get it faster, get it better, because if you are not successful in what you do, then we're not going to have the products that we need. So we have to make sure that finally we close the gaps in oversight. And I'm not a heavy bureaucracy person, but I do know we've got to close the gaps in oversight on genetic tests so that people will have confidence that when we say something works, it really does work and that it is safe. We also know that, and I've just basically talked about this, and the other thing I guess I would just simply indicate is what's going to be very important is something called coverage with evidence development while the clinical trials go. And that basically is when you cannot do your normal randomized controlled clinical trials, and when you, for lots of reasons, in genetic space will be a space where that will be a challenge, we will have to find other mechanisms of getting the data. And then the question is, how do you have a conversation with the people that have to pay the bills to say, hey, let's try this. We'll put it into insurance coverage even though we don't have the evidence, and we'll collect the evidence as we go. That's a tough check for an American business to write because they are already at the end of their rope on health care expenditures. This is a very fragile, but also potentially pregnant opportunity, one that has to be looked at very carefully. Then we have to help our physician colleagues. Norm Kahn is here and from the Council of from representing all the medical societies, the specialty societies, and I think we really are going to have to help them have information at the point of care to be able to make good decisions. These are well-meaning people. The increased complexity of healthcare, says the IOM, means that we have to have new learning healthcare systems that use information and feed it back in intelligent ways. And so we have today systems that are fragmented. The genetics community fragmented from the specialty community, fragmented from the primary care, the public health people separated from the clinical care, the pharmacy people separated. Everybody's separated in their silos. Information is going to need to come together in a variety of ways to be able to pull different pieces together, collect the aggregate intelligence, analyze it about people, make it liquefied, make the data and analytics liquefied, and then drop it onto the delivery system so that we can have actionable intelligence at the point of care. And so a lot of energy is going into that now. And what we will be, I think, looking to is how does the genetic information, how does the genetic guidance get built into these in a seamless way so you can have evidence-based alerts. So you will know whether or not you are practicing consistent with guidance, that you'll know where the variation is in cost, because that's going to be so very important. Not only will you need to know what diagnostic procedures that you're ordering that you shouldn't, but which ones are we not ordering that we should? And how do you build it in to these kinds of decision connection grids? I will tell you that this will be on steroids in the days to come because of the reimbursement changes. And I think most of you in this room are aware, but those of you who are not, let me help you to understand that fee-for-service is dead. It is going to die. It will be stamped out with everything that everybody has in their might, because you just can no longer run a delivery system this big under these kind of economic pressures where people are rewarded for piecework. Piecework won't get it anymore. What you will see are people who will be reimbursed for the outcomes, both quality and cost-effective, for managing populations of enrolled people, groups of people. That delivery system is moving forward now, moving from on the horizontal axis solo practitioners to more virtual networks, to IPAs, independent practice associations, physician and hospital organizations, multi-specialty group practice, to ultimately fully integrated groups. Reimbursement moving from fee-for-service to bundled services for lots of things, episodes of illness payments, and ultimately to global risk models. The point being that we will see multiple permutations all along this chart. Things will be scattered all over the place, but they will certainly move from the lower left quadrant. The point being that the incentives financially will be for the delivery system to get it right. And so it provides a real opportunity. Performance measurement in this space, as genetics becomes medicine, will be increasingly there. So that in this case, I used an example outside of genetics, but for just cardiovascular disease, there is enormous transparency around which are the best cardiac centers. We know which ones suck and are really expensive. We know which ones are great quality and lowest cost. Guess where the business is going? Guess where patients are going to be incentivized? And guess which people are going to enjoy new revenue streams as they get paid more because they save money because they're better quality. And so they will be the ones who will win. There will be winners and there will losers. Those who are providing genetic-based services, either as standalones, but more likely as integrated within larger delivery systems, you will need to be very skilled and be clear that people will be looking to see how well you do what you do. Nobody gets a pass anymore. And so there's an urgency to develop and implement coding for genetic tests so that we actually will know what people are doing. We'll also have to be able to track tests downstream. This is very frustrating that we don't have the codes that tell us what's going on. This is a high priority area that needs to be developed. And then as I start to close out, let's also remember there's a huge amount of data being spun off in genetics, as we've described. The challenge will be to ensure its privacy, confidentiality, and protection. I am, like many of you in the room, terrified about the trust question. This is sensitive stuff. People look at genetic data differently than they look at other data. That trust concern a few years ago was so great that people didn't want anybody to have access to it. And so the very people who have chronic illness the most, who needed an integrated, connected delivery system that overcame the fragmentation of silos, the people that needed an integrated, seamless, patient-centered delivery system the most were the ones most afraid of having the data that would be necessary to be able to achieve their goals. I think we're in a different place today than we were then. But that only means increased vigilance around this issue, and so I wanted to underscore it with as many explanation points as I had left to me. The challenge will be to integrate genetic data inside of other data pools and then to make sense out of it. This is the era of big data everywhere. Data is just huge and everywhere, growing at 50% per year, more than doubling just data in general. Data like that can measure and communicate location, movement, vibration, temperature, humidity, even changes in the air. Why did I use up the last couple minutes that I had to say those words? Because guess what? We got new Band-Aids that have sensors in them, which measure humidity, fluid, change in temperature and scream out, "Help, I'm infected." Pay attention to me. Something's going on under here. So my point is that healthcare is all into the midst of this revolution. And so I thought that Eric Vazov's comment was very interesting the other day. To grasp the potential impact of big data, look to the microscope. Invented 4 centuries ago, it allowed people to see and measure things as never before at the cellular level. It was a revolution in measurement. Today, data measurement is the modern equivalent of microscope. And these things make it possible to measure behavior and sentiment in fine detail as it happens. And so how do we take that and make sense out of it? So the issue now becomes with genetics is we know, just as in other areas of healthcare, who we need to talk to. Mrs. Jones, 55-year-old African-American woman with diabetes and congestive heart failure. We know what to talk to her about. Mrs. Jones, you did not get such and such a drug, which you should have gotten based upon your clinical profile. Now the question is, how do we talk to Mrs. Jones? In healthcare, we would hand you our brochure. Just say no. Just do this. It's 4 colors and it's very pretty. And it works well as a generic thing for everybody. Well, you all know darn well that today that ain't going to cut it. And so understand that people are different and they respond to very different triggers. Some people want an internet site, and that's terrific. This is a shameless plug for my new book. But no, it's actually, I talk about the barriers of how is it that people, what keeps people from using information the way they want. Some people want to read it in a book. Some people want it on their cell phone with new kinds of mobile apps that are very personal to them. Some people will want that conversation to go between a patient and a physician, and ultimately we know we're going to need the 13 genetic counselors that are still around somewhere who are going to be like enormously overworked. 13. There's no difference between 3,000 and 13. We need more of these geniuses. These are the most important people that we will find in this conversation. And how do we maximize their utility is one of the great challenges going forward. But the point is, we've got all kind of new ways of reaching people, and the brochure ain't it. And so what we have now the chance to do is to integrate the genetic education, the genetic counseling, the genetic thinking into the mobile apps of the future. Well, that's just a quick tour through some of the things that are the subject of this meeting and the things that will continue to benefit from your genius in the days to come. I guess I would just conclude by saying I am really excited, like most of you, by the possibilities of this moment. I am extremely aware, though, that just because we are excited doesn't mean diddly squat. Just because we love this stuff doesn't mean diddly squat. Just because we know that so many of us in the room are standing on the moral high ground, caring and fighting as you should for every patient, especially those who have no treatment today and who, gosh darn it, deserve and demand and need something for their kids so that those kids will survive and maximize the full extent of their God-given human potential. We absolutely know we're standing on the moral high ground, fighting like hell for every one of those things. And all I'm saying to you is, in addition to that, if you are really, really serious about this, you've got to make sure that we are doing all the other things that are necessary to sustain the ability for those things to come to life. And that means that we've got to be cost effective in our development of new innovation. We have got to be clear about proving the point, what works and what doesn't. We have to understand value. We have to make sure the delivery system knows how to use it and doesn't piss away the money so that we can't afford access to it. So you have to be clear about helping physicians do right, which means you've got to go beyond rhetoric to implementing it inside of new decision support tools. And then finally, we have to help people to know how to use it, both for prevention of disease and the amelioration of disease once happening through, again, individually supported decision making so that we use these assets intelligently. This is a job for us in this room. It's a job for people that do Google. It's a job for people that make apps. It's a job for the Apple people. It's a job for a lot of strange bedfellows being brought together. Thank God for the leadership of the Genetic Alliance.